Good evening, everyone, and thank you for joining us tonight. I want to welcome you to our webinar entitled Practice Building in IR, hosted by a great panel of interventionalists tonight. On behalf of the SIR-RFS, my name is Jason Fisher. I'm the incoming communications chair, and I'm a PGY1 in surgery at the Mount Sinai Hospital in New York City. Tonight, I have the pleasure of introducing our organizer, Dr. Tad McGuire from Medical College of Wisconsin, along with his panelists of attendings who will be introducing themselves. I just want to remind everyone tonight of a couple quick disclaimers on behalf of the SIR. Tonight's webinar will be recorded and subsequently uploaded to the IR Education YouTube channel for viewing later on. And we encourage everyone to ask questions that go along to the panel. I found that typically the best way to do so is using the questions chat box on your GoToWebinar control panel. Just allows the presenters to keep everything organized and kind of address questions as they go along. So without any real further delay, I'll change it over to Dr. McGuire here to begin the panel on practice building with a focus on the interventional clinic.
Hey everybody, thanks. As you said, my name is Tad McGuire. I'm actually the incoming clinical education chair. And I've got a great team together tonight to talk about practice building. I'm gonna let them introduce themselves since you're here to listen to them, not me. So thanks for logging in. There we go. All right. Can you hear me, everybody?
Yep. Yeah, I can hear you. You know, I'm going to re-log in really quickly.
Okay, no worries. Do you want to just?
I can get started.
Yeah.
Since looks like top of the roster here. This is Venu Vadlamudi. I'm a neurointerventional and body interventional radiologist in Alexandria, Virginia, in a private practice group, Association of Alexandria Radiologists.
Hey, my name's AJ Gunn. I'm an interventional radiologist at the University of Alabama, Birmingham.
Hey, everyone. This is Srini Tummala. I'm a peripheral interventionalist, University of Miami Health System, and I was in private practice for about 15 years before going into the academic setting.
Hey everyone, this is Kumar Madassery, one of the interventional radiologists at Rush University Medical Center in Chicago. Started and stayed in private practice since starting, so good evening.
Hi everyone, this is Sabeen Dhand. I'm from PIH Health in Los Angeles and Whittier, California. So private practice and have been in that practice for 3 years now.
And I think it was Dr. Pereira re-logging in. He's still listed. Okay, he's still listed. No worries. So we'll have him jump back in as we go. So I guess right off the bat, we'll kind of just hear from everybody about maybe just a little bit about their journey into IR, what brought them into it, and how they heard about it, and maybe just a little bit of background, kind of how you got involved in the field. We could use the same order if you want, or we can just, or if anyone just wants to jump in and we can like answer one question at a time, however we'd like to do it.
You want to start, Venu?
Yeah, sure. So I've been in this same private practice group now for a little more than 4 years, now my 5th year of practice, and this is my first job coming right out of training. So far, I really only know the private practice world in that sense. My clinical focus includes on the peripheral side of things, things like PAD, including critical limb ischemia, fibroids and women's health diseases. And then on the neurointerventional side of things, things such as stroke and also kind of unusual procedures. One, for example, is a large volume spinal blood patches. So sort of a niche kind of an area. So the practice that I'm in allows for kind of a broad array of interventional skills and types of patients that we come across, and also some ability to have some niche areas of interest.
This is Srini Tummala. So I actually got interested in interventional radiology because I had worked with David Williams at the University of Michigan as a in between my first and second year of med school. And while working on that project, he took me to his the angio suite. I spent weeks with him in those labs while he was treating patients. And at that time, it was a lot of diagnostic angiography. And so he really talked about hemodynamics and physiology and flow mechanics and so forth. And so that's kind of what got me initially interested in interventional radiology, and then eventually went on to train. Our practice right now is kind of all the major service lines, including vascular disease like Venu, PAD, CLI. We've got men's health, women's health, and interventional oncology. So we have a pretty diverse case mix at this point. We don't do much aneurysm work, and that's probably the one thing that's lacking. But we also do a lot of acute and chronic DVT and venous interventions as well.
Great. Anybody else?
Yeah, this is Kumar here. Honestly, I found IR accidentally, like everybody else here. I was a surgery intern, didn't know anything about IR, and just was not looking forward to continue with surgery for whatever reason. And a couple of my seniors had said, "Why don't you check out IR?" And the first question was, "What is IR?" Which is kind of fast forward now. It's nice to see that we've all worked so hard, and our leaders kind of helped come up with the residents. Paramount now for us. Our practice at Rush, we're a very comprehensive tertiary care center. We do a combination of mostly all the endovascular, aortic, and lower extremity work. I try to focus on critical limb ischemia and the complex cases with that, but we also do a wide array of complex obstructions, oncology, so kind of the whole gamut. I think there's a lot more to improve from the outreach clinical side, but I think as a whole, we're all going in the right direction. So excited to have some webinars like this where we can talk about all that.
This is Sabeen, Dhand here, and yeah, I kind of fell into IR accidentally. I randomly picked up a IR project after the first year of my med school, and I ended up working with Bob Vogelzang and Robert Ryu, dealing with uterine fibroids, and I had no idea what IR was at the time. And I went into the IR suite and just fell in love basically with it. And I after just meeting the people and seeing that everyone in IR was pretty easy to get along with, then I found out the procedures were really great, and it just went from there. So my practice is also pretty a wide variety of cases, but we do have a focus on critical limb ischemia, interventional oncology, and stroke. I would say those are our three big things we do in our practice, and as well as a lot of dialysis work.
This is AJ Gunn. For me, sounds like I'm just like way different than everybody else, but I pretty much knew going into diagnostic radiology residency that I wanted to do IR, and that's just because of some exposure that I had as a medical student. So it was kind of planned, from the get-go when I started my radiology residency that's what I wanted to do. I think the things that we do with and again, maybe a little bit different as practice-wise is that we are a pretty typical academic practice. I would say we don't really do a lot of peripheral arterial disease. Obviously, vascular surgery has been doing a lot of that for us, but our focus has been a lot of interventional oncology, tumor ablations, kyphoplasties, vertebroplasties, obviously fibroids, and everything else that everybody else mentioned. So, but that's kind of what drew me into IR in the first place, was the oncologic aspects of it. So I don't feel like I'm missing anything, but that said, I really do enjoy the oncologic aspects of all the things that we do.
All right, thank you. Do we have Keith back yet? No. Okay. I think he's still logging in, but yeah, thanks everybody. One thing that kind of came up as a common theme was, there's initiatives to kind of the IR interventional radiologist as a clinician. Obviously, it's the theme of the webinar, and something that people tended to ask about. Just the evolution as you were coming through training. Were some of these things changing? Were you trained in such a way that you were kind of a technician or a proceduralist, and then sort of come into the clinical role, or did you come through or was your training more in the clinical model and long-term follow-up? That is kind of the newer wave, I guess you could say.
This is AJ. Sorry. I was just gonna. I think, when I came to UAB, like they didn't have a clinic set up yet. That's one of the things that I did when I got here, and I think we talk a lot about like clinics and setting up all these kinds of things, which are great, and I think they're super important. But I think when you talk to, at least when I talk to friends that are out in private practice, like that clinical model isn't as is permeated out into the rest of practice as we probably think that it is. And so it's not so much, at least in my experience, it's not so much that whether or not the interventional radiologist has the ability to clinically handle a patient. It's really more managing, your referring physicians and that they trust you, and they see you as someone who can take care of your own patients, someone who's going to admit your own patients. And so, to me, that's really been that's been the biggest thing, is just educating referring doctors about the stuff that we do. We have an admission service and a clinic, and they love it when they hear about it. But I think that to me is always the uphill climb, is that they've just always seen IR is radiology, and radiology, you send them something to do, they do it for you, and then they send the patient back. So that's really been the uphill climb that I think we're all kind of, in the midst of right now.
So,
at Rush, I think one major difference that helped us become better visible clinicians is that we converted everything to a fully consult-only service in the entire electronic system and in the hospital, where years ago, and I think a lot of places, it's basically orders are put in and we carry those out, but every patient gets seen, whether it's a PICC line or an aorta, and they get worked up, and we kind of give our recommendations as to what can be done and when, not as in we'll take care of it. I think we have to take ownership of that and make that visible around the hospital, and that's still something that's being propagated around hospitals around the country. I think we need to make that a standard. We need to see every patient in our clinic before and after. That's also something, despite in many years we have physicians who don't know we have a clinic, even though they've walked by it every day. So that's something that we all work with and try to do a better job of educating and marketing. It's something that wasn't focused on, a decade and a half ago. So I think we're on the right track. There's a lot more to go with that, but taking ownership and letting others understand that we will give our best recommendations, similar to any other full consult service in the hospital. That's what helped us quite a bit.
I think AJ and Kumar bring up two really important points. I mean, I'm kind of, but I trained at a time when, there were very few programs with a true clinical model. I mean, I trained at Miami Vascular back in 2000, 99, 2000. And at that time, they were doing exactly what Kumar is talking about and what AJ is alluding to. And that is, everything was a consult. There was no way to order an IVC filter placement or a biliary tube or whatever it was. You had to order they would call it an MVI consult. Consult the MVI team. And then we would do exactly what Kumar and AJ are talking about. And what that did is that really elevated us away from our diagnostic colleagues, because at the end of the day, we do suffer a little bit from the radiology in our name. And the only way to turn that around is exactly what AJ and Kumar are talking about, which is you're affable, you're available, and the minute they call you about something, there's no fighting that we're not going to do this or what are the labs, but it's rather, we'll take care of it. And that means seeing the patient as quickly as possible, ordering whatever tests and labs we need to do, giving our recommendations, putting a note in the chart, consults, and so forth. The one thing I will say, though, with the consult model, because we changed ours at University of Miami recently, is that we've actually started categorizing the procedures. As we all know, there's level 1, level 2, and so forth. And so for things like central venous access, thoras, paras, and things like that, those are actually just get managed very quickly by one of our nurse practitioners or PAs. Once it gets to the more complex procedures, when you're talking about level 2, 3, and so forth, then it starts triggering, okay, this has to be seen by a fellow, a doctor, and so forth. And so that's one thing we did, because otherwise we get inundated with so many minor procedures that are done by our nurse practitioners and PAs, we didn't want that to bog down the system as it was when we initially switched over to the consult model.
That's great adjustment.
Sorry, this is AJ again. Sorry, but I just want to follow up something with both Srini and Kumar, and please feel free, anybody else, to answer about this. But Kumar said when you see, Kumar, did you mean when you see every patient that you do procedure on? Do you really mean every patient, like pre and post, or is it kind of more like is Srini talking about where it's certain procedures?
Every patient that's being that they need us to see do anything on, see anything, and we will there's a consult order to interventional radiology, and that patient will be seen and worked up on a full consult, whether it's a PICC line, whether it's a drain, whether it's a leg. That's just policy. I mean, doing that thorough workup, we've been able to teach our fellows how to catch certain things like central occlusions here. Their access may be different. Sometimes the PICC lines and stuff, our residents and our mid levels can help us with as well. But there are things that you catch in those things that are teaching moments. So just as a blanket policy, every single patient gets a consult, a full workup.
And I will say this though, AJ, is that being in both models, and Venu can speak to this too. I was in private practice for a long time, and I came out of a very heavily clinically based program with a lot of consultations and so forth. And the problem is a lot of the private practices function under a much different model, even if they have high-end interventional radiology going on. They actually don't like the consult model because in private practice that requires a lot more FTEs, a lot more mid-levels, and a lot more people and resources to kind of help out with that process. And so when I was in most of the private practice groups I was in, it was really, there was no consult. They would order a procedure, but then we would treat it as if it's a consult, even if they asked for something. So I want a biopsy, I want a filter, whatever it is, I need an angio. Even though it came across as an order, we would basically give our recommendations, see the patient, all the things that we're talking about, and then call the doc and act as if we are doing a consult. So even if you don't have that infrastructure to do that, because remember, that requires a lot of money and it requires the IT portion and so forth, a lot of these private healthcare companies, whether it's HCA and Tenant and so forth, they don't want to spend the money to convert you over to that without a lot of action and discussion and so forth. And so that's something you can do kind of in the midterm before you get to the ultimate, which is what we want, is what Kumar is talking about.
Yeah, I agree with what Srini just said. Is in a private practice, you might not have the manpower to see every single consult, and then we get the orders in, and basically we will see consults for higher levels of cases like peripheral arterial disease, critical limb ischemia, other GI bleeds, just things that are a little bit more complex. We will see the patient, but the more or less complex procedures like a biopsy or thora, things like that, those tend to, we pretty much vet out the patient just by reviewing the medical record, and then we see the patient when they come down to IR. But that's really just a manpower and money thing.
Those are very, very appropriate kind of situations that everyone has to kind of understand and adjust to. But I think also in the training part of the system, that's kind of we just kind of make that a mandate so they understand in their training period this is kind of how you do it and what you might look for, and then you can adjust that when you go out to your own practice, and at least you have that background and you understand the importance of each and every one of those. A PICC line can go sour and you're in trouble. So everything deserves a full workup, but that's again because of manpower we're able to, because of training levels we're able to, and mid levels.
Hey guys, this is Venu here, and yeah, similar to what Srini was just talking about, and even in Sabine's model, we in our Epic system actually still unfortunately have kind of the ability for orders to be placed and consults to be placed. We do ultimately treat almost everything as a consult, but as Sabine was alluding to in his practice, and we have something quite similar, if it's a thoracentesis or paracentesis request, for example, we generally do not do a full consult on it, but we still vet the case, look through the chart, look at the imaging. That being said, what we look for are also, frankly, opportunities as far as how can we potentially help that patient or that clinician better. It may turn out that the right answer is not necessarily a paracentesis, that, hey, have they been evaluated for potential tips? Maybe that's not come up so far. So we can, kind of parlay some of those sort of seemingly simple requests into a consult, into another way to help the patient. And just as a case of late that came up, long and short, was a mid-40s female, came in with DVT and PE, and I was on call. Her hemoglobin was 5. They said, okay, hey, can we start her on heparin, but we want to consult you regarding putting an IVC filter. So I did that consult, pointed out, well, a filter is not necessary. They could resuscitate her. But we got to the bottom line of why her hemoglobin was 5, and it turned out to be uterine fibroids. And then so I saw her back as an outpatient once she was through that acute issue with the DVT and PE to discuss fibroid embolization, and then subsequently treated her for such. So you can take a seemingly simple IVC filter request, which could be an easy enough, okay, yep, no, they don't need a filter, see you later, but you can parlay that into some way of helping that clinician and, of course, helping the patient.
Hi, can you guys hear me?
Yes.
Oh, I can. Okay. So just a quick introduction. I'm Keith Pereira. I'm from St. Louis University. Went through a few questions that I missed out on. Clinical focus is on PAD and more embolizations, PAE and UFE. Evolved from I did my fellowship a few years ago where there was no consult system. This is an interesting discussion, and from there on it has moved a lot, and now the practice that I am is similar to Kumar, and I think he raised valid points. We want every fellow or resident to understand what a consult is. It may be for a biopsy or a drainage, but it's important for them to know. And a drainage is, life-saving for patients sometimes. So, a TIPS is life-saving, a drainage is life-saving too. So that's where we come from. Every patient gets a consult. Now, my question to the guys in private practice is, how do other specialties manage with consults? Like, for example, vascular surgery. Do they have some stuff only in orders and some stuff in consults only, or is it like how do they survive with the reimbursement?
Well, you got to remember, Keith, with other specialties, when you're alluding to you're talking about vascular surgery, their infrastructure is set up differently from the beginning.
Right.
They're set up to be a consult practice, an office-based practice, inpatient and outpatient, and so forth. If you're in private practice and you're joining an existing radiology group, and there may be 12 people, there may be 100, they have set up as a diagnostic radiology practice first, and then the IR piece is usually kind of molded or, brought into the system to fit into that practice. And remember, typical radiology practice, and Sabine and Venu can talk about this, your overhead is maybe 15%, maybe 20 if you're spending a lot of cash. Whereas a typical surgeon's overhead is more into this 50-60% overhead, because they've got somebody answering the phone, somebody doing authorization, so forth. Whereas a radiology practice, their overhead is so low, to get all the partners to agree to having a clinic and nurse practitioners, PAs, and so forth, they have to have buy-in, because it means spending more money, having a higher overhead, and that eats into the bottom line. and there's a little bit of a disconnect between diagnostic radiologists and IR docs, regardless of what people say. My cousin's an interventional cardiologist. He has it within his practice. He's doing tons of interventional cases, and they're saying, how come you're not reading enough echoes, EKGs, and stress valves? You can get the same thing in a radiology practice in a different way. And so you have to understand that their model is set up in that way from the beginning. And I think this is where our IR residency will help. I think this is where the young IR docs coming out, like Sabine and Venu and all these guys who are aggressive, they're in type A, they're intense. We're attracting different personalities into our specialty now. I think that's going to slowly start changing. And especially as people are joining kind of IR-only practices or multi-specialty groups, you're going to see a huge difference, I think, over the next 10 years.
Oh, those are valid points. So I guess what Kumar and we are doing is in the right direction, right?
Yes.
Okay.
I think the complication that you're mentioning with having radiology partners buy in and all, that's something very true, and I think that's something we have to teach our trainees of what to expect. And also, this is also why we need to move towards independence in IR and globally. And there's a few places that have successfully done this, and I think that should be our overall goal, because we, as a society, as a specialty, we have to expand within ourselves and make sure we're not hindered by any of that. So I think going forward, we teach our fellows and trainees, and now with the IR residency, we're trying to train 100% clinically oriented IR trainees. And I think we need to give them the right tools and abilities to develop that wherever they go. It's going to be a long process, but I think we're farther now than we've ever been before. So I think we have to keep working towards that.
Guys, this is Venu here. I wanted to piggyback actually on Kumar and Keith's points and really applaud them, for the way that they're training their residents and fellows, because I think that's really absolutely the ideal way of doing it. Really treat everything as a consult, and depending, of course, on what kind of a practice you end up in, you figure out. But it's a lot easier to go from that sort of mentality and then figure out how to fit and morph to let's say in a private practice model. And as Srini was pointing out, unfortunately, most of those private practices are under the larger umbrella of a combined diagnostic interventional group, and so the infrastructure, the setup, just is really not necessarily intended for that. And even in our practice where we do, all of us do full-time IR, we do, low end to high end and everything in between. But that being said, it's not that, we don't still sort of hear the sort of typical rumblings and mumbles and things like that from our diagnostic partners about, productivity and RVUs and that sort of thing. But, and again, I think that's where, giving perspective to trainees that, well, you take that consult, or I can list innumerable examples of taking a 20-minute phone call to a doc, and that is going to translate into not just helping a particular patient, hopefully, but really down the line getting more patients, getting more consults, and also that means more imaging for the group. And so that's often what's difficult for diagnostic radiology partners to see, because it's not the sort of immediate effect. And so I think coming out of training with that mindset of, this is a clinical service, this is a consult service, and then morphing to whatever the practice needs is the key.
Dr. Madassery said something about independence in IR, and just to clarify, did you mean all like IR only groups, not as in totally separate?
I think the pipe dream of everybody in IR and academics everywhere is to be your own IR department, area instead of anything else. That's why OBLs are so alluring to people, to kind of run their own practice, be the only person, be the only team. And I think, the only way we get away from having to deal with issues that, maybe sometimes seem as a hindrance, or, difficult conversations about productivity and all that, is to eventually get on our own. I mean, you don't want to break off completely in that mental sense, but in reality, that's the only way we succeed and we expand.
Sure.
I think something important too to think about is that, and I think most academic institutions now with the with the integrated IR residency and the independent IR residency are training more clinically oriented residents and fellows, and that's great. And then, but I think sometimes too, when they go out into practice, it's not, it's never like exactly how it was where you were training, right? And so a part of this also, as far as practice building goes, isn't just having the ability, it's kind of having the emotional intelligence to read the room, and I think, whether that's in your own group, whether that's in your own department, or whether it's your own group, and kind of knowing like how far you can push before people are going to get annoyed with you, or whether it's in the department or the hospital. I mean, there's all of that, because I think, when you're starting off especially, I mean, there's just nothing more annoying than having somebody keep talking about how it was where they were. You know what I'm saying? And so somebody shows up to a new place, and then, you can only push so far before you start to get pushed back. And so you got to really, as far as practice building, it's not just gaining those skills, which I think a lot of people are going to have. It's also kind of like reading the room and understanding where your partners, where your department, where your hospital is, and, not forcing what you want upon your referring doctors, but seeing where you can kind of meet them in the middle, right? Because it may not be everything that you want, but just because you don't get everything that you want doesn't mean that you guys can't work together still, right? It doesn't have to be one way. And I think that is, once they see you as a partner instead of a competition, at least in my experience, once they see me as a partner instead of competition for what they want, or for procedures or for patients, the practice building has gone much smoother.
I think AJ brings up a good point, and that point is, when I finished my training, the one thing they told us, they said, keep your mouth shut for about 12 months, do good cases, don't be a cowboy, have a low complication rate, and learn the system, learn the players, meaning your other partners, your colleagues, the referring docs, the healthcare system, the institution. And then once you've had a chance to kind of show people that you're a good doctor first, then start moving into trying to say, hey, what if we did this? What if we did this to practice build in a different way and so forth? So what AJ says is a really good point, because I did notice that when I was a practice.
Yeah, hey, this Venu here, and yeah, to piggyback on Srini and AJ's points, excellent points. In fact, I would actually sort of venture to say it's probably more like 2 years, to kind of get to know the lay of the land, and frankly, for referring docs to get to know you. I mean, nobody knows who you are come July 1st. You're a nobody, and you could be the world's best fellow who just finished training and very, very bright and all that, but unless you're staying in the same program where you've been, it's very unlikely anybody truly knows you. And it takes some time to develop those relationships, for people to view you as a trustworthy resource. Of course, all of the, kind of A's that we hear about: affability, availability, ability. And so all of that takes some time to really kind of build up. And, once you sort of keep your head down, as Srini was alluding to, don't go for sort of cowboy type cases, really try to have low complication rates, seek help from your partners, look for ways to grow, because there's a lot of growth that occurs in those first few years in practice, no matter what your setting is. After those first couple of years, I think you'll really start to see, I know personally I saw after about 2 years or so, it was like a sudden ramp up in the volume of cases and consults and clinic patients that I was seeing personally. And so, it does take that time. You do have to sort of keep your head down and work at it, but it's ultimately worth that, hard work. But it takes time for people to, work to the point where they trust you with their patients.
Yeah, I'd like to, reiterate what Venu said. And I do think it's about 2 years, and that's where I saw a big difference in my practice, and where then the clinicians were calling me for most consults. And being available and keeping your complication rate low for those first year or two is so important, to kind of build up your reputation.
Venu mentioned. Oh, sorry. Is that Kumar?
I was just gonna say, sorry, it's Kumar. These are all fantastic points. And I don't know about you guys, but that first year out of fellowship is when I think you learn everything that you thought you knew.
Yes.
I never spent so much time reading articles and pictures and cases, almost rehearsing it like a football game before a case, as I did that first year out. So I think when you first get out of training, that's when the humility should kick in, and you actually ask for as much advice as you can. And nowadays, with our social abilities with the internet and communication, there's so many ways to ask for help now, and get the senior help if you don't have it around you. I think everyone should be very humble and very very careful, because the patient's on the other end of this. So I think it's a progressive process, but with the right tools and training, those all will kick in as you go.
Yeah, Kumar. I mean, I remember doing my first GI bleed a month or two out, and it was 2 a.m, and I just had this very stark realization when I look back at the control room. It's who's watching me doing this, right?
Right.
Who's going to say that this is going to be okay? And I think what you guys are all saying about, when you do, the scariest doctor is the person who doesn't know what they don't know, right? And so practice building isn't oh, I know all this stuff, and then I'm going to go out and show everybody how much I know. It's actually continuing to learn, continuing to grow, understanding what other specialties have to offer patients as well, and where IR fits into that and where it doesn't fit into that. When you ask for advice of people, sometimes people ask for advice only wanting to hear what they want to hear. And I think sometimes when you ask advice of people, you actually have to really, accept that advice and say, okay, they might give me a different perspective, and I'm going to need to learn from that. And so it's a huge growing process for sure.
I'll tell you what's interesting about that too is that, even if you come out and you think you're a hotshot, those first few cases you do, you start even if you did that procedure or that type of therapy 100 times before you got out. You start noticing all these things on the screen that you'd never noticed before. At least I did. And that was very eye-opening. And what Kumar and AJ are talking about is right on. It takes a couple of years to get used to that. But I wanted to raise another point, and that is that we don't do a good job. We have 8 fellows a year, 7 this year actually. And one thing I've noticed is that we don't do a good job teaching our fellows and our trainees throughout residency how to practice build. How do you talk to a doc? How do you convince somebody that you're an expert at something and they should send you the patient? You know, we're so used to people just sending us stuff because they know that, oh, well, IR does tips, IR does this. But remember, there's a lot of procedures, a lot of therapies that we do that a lot of other competing specialties are involved with, which we all know very well. And those specialties, through the years and kind of through the ranks, they understand that when they get out, they're going to open up a shop, they're going to get a business card, they're going to sit in a lunchroom, meet and greet, they're going to say hi to people in the cafeteria, they're going to hire somebody to do authorization. So they have a much different idea of what they need to do when they get out. I talked to our fellows, and 6 months into it, I'm like, how are you going to practice build? And they say, well, I'm going to join a group and I'll see what they send me. So I think that's one thing that we can do a better job of. At least I can try to work on it. We're actually working on a curriculum for that. How do you actually practice build when you get out into a practice, whether you're solo, meaning you're part of an IR group, or multi-specialty group, or part of a radiology practice? I think that's an important thing.
Yeah, Srini, that is a really good point. I mean, I think a lot of times we just rely on modeling. I think, like that as long as my residents following me around, that they're going to pick it up. And I don't think that's probably true, because I end up getting a lot of like phone calls and texts for people that have already graduated, kind of like, how do you do this? How do you do that? What are the protocols that you guys have for this? And those different kinds of things are all really important. For us, at least on our end, one thing we've really tried to do, and this is just for the people that are listening, sometimes as a fellows or resident, like, you're super busy, and so, everybody wants to be doing procedures all the time. And so I find sometimes I have to really push my residents and fellows to, like, stay in clinic, to walk up to the floor with me to go see a patient after we've done a procedure, or walk up to the floor to go see him the next morning, or we've set up, a bunch of multidisciplinary conferences surrounding a lot of different disease processes, like to grab a fellow and say, hey, it's important for you to come with me for this hour, and because they all want to be doing procedures, and I get that. But, I guess in our end, we're just really trying to get them, out and seeing the different things we do, how we interact with different physicians is how we've been doing it. But I'd be interested in what others' experiences are as well.
Yeah, I think, hey, this is Venu here. I think these are, very good points. And Srini, and AJ, you guys are talking about, well, how do you sort of teach these things to trainees? Because you're right. I think that's been a big gap in, IR training. I can't say that I particularly had a ton of practice building, if you will, as part of my training. I had a very good, clinical IR fellowship, but practice building, I really figured out, actually kind of learned it a little bit more so during my residency, just because it happened to be in a sort of pseudodemic kind of program that was really based out of private practice model. And so in that residency, I actually worked on things like, brochures and cards and office visits and those sort of things. And so that's where I kind of learned a little bit of that from a, ground level. And then when I joined, this private practice here in Virginia, it's also not a thing that you just sort of do once and you never have to think about it. It's actually a constant work in progress to do practice building. One of the things I think that trainees should sort of keep in mind, and I don't think that it's a unique thing in my practice or my area here, but people can have a short memory. You might be a great clinician, you did a good job, you helped this patient, and then a couple of months later, oh yeah, I forgot you're there. I forgot you do that thing, and so people can really have a short memory for stuff, especially in an area such as vascular disease, where, hey, there's frankly other people who do it too. So you have to be, out there. You have to sort of prove your value to them. You have to be available to make it worth their while. But also, I think there's a certain amount of sort of constant reinforcement that really just keep yourself front of their mind.
Excellent points.
Definitely. Any extra training? This was also something that came up, was extra training, things in economics or even like an MBA, specific business training, or even if it's not a full MBA, something akin to that should maybe be factored into IR training now that we have our different training pathways and they're being developed, and we're going to have a longer time to train more clinical IRs.
I mean, I think you can try to include as many things as possible, but then, you know, at some point, you know, you only have so much time to get people ready. You know,
Sure.
I think, you know, ideally you would want people to understand, you know, healthcare economics, how it works. You know, if you've ever spoken to, and all of us have, you know, to the CFO or the CEO or COO of a hospital or a healthcare system, you know, you got to remember, at the end of the day, they look at us and they say, okay, you're an interventional radiologist. You guys do great stuff. That's awesome. But we honestly just want you to take call and take care of the stuff that lets patients that are in the hospital get out quicker. We want to reduce length of stay. Yeah, I know you can offer all this fancy vascular disease and this and that, but we have other people that are going to do it even if you don't do it. And so if you understand how the other person thinks, and that's namely the MBAs, the business people in your healthcare model or system that you're in, that'll actually help you determine and come up with an argument and back up what you need and convince them of what they need. Look at what cardiologists go after, right? They went after STEMI. It's a very glamorous thing, right? Heart attacks. We got a chest pain center. What's next? And Venu and all of us know about this, and Sabine and everybody. Stroke. That's another big glamorous thing for a cardiologist to do. Now a lot of the cardiologists want to do PE because, again, it's another kind of glamorous, we're saving somebody's life. And so what you have to realize is you have to elevate yourself within a healthcare system to show that you put in some worth and some value. And there's many ways to do that, but that's something to kind of keep in the back of your mind as a trainee, as you're going through the ranks and reading and trying to learn and figure out what to do when you get to it.
Those are excellent points by Srini. I don't know if you necessarily need to have an MBA set up in there, but I think now that we have a multi-year training program where we have these trainees for quite a bit of time over their training period, there's a lot of ways we need to find a way to incorporate the true art of practice building and how you need to do that. I think that's something we should work on, and that's something where I think we are lacking in the initial planning phases. But that's a great point that maybe we should all consider to incorporate regularly into their training so that it gets into their head of these all processes, and as they go to clinic and as they, you know, see the patients and all, that's something they can incorporate. That's an excellent idea.
We've actually at UAB have a business of radiology course that they have like these lectures kind of all throughout their residency to kind of help these kinds of things. But, you know, I think as someone else said, you really only have so much time, you know, and to me, you know, it just, practice building isn't all about the economics of it. You know, practice building, a lot of it is part of it is economics of it, and part of it's expanding your base and making sure that your group's profitable, those different kinds of things. But part of it's really about, like, you know, expanding the relationships that you have inside the hospital with patients and with referring physicians in order to increase the you know, the care that you can provide for people. Because really that's what it's ultimately, at least for me, that's what it's ultimately about, is, you know, being able to provide patients with minimally invasive care that's kind of get them better faster. And that's kind of how I think about these things. And so, you know, in that sense, if for people that are listening, if it sounds overwhelming, it is a little overwhelming sometimes, because do you focus on the business aspect? Do you focus on the procedural aspect? Do you focus on the mentorship aspect? I mean, there's all these different kinds of things. And, you know, for me, one thing that's really helped is just to kind of, you know, set a goal and make a plan, and just bite-sized little things. Because if you sit down and say, okay, now I need to make, you know, now I need to redesign the website. Now I need to, you know, make flyers for all the different procedures that we do. And now I need to go do all these different podcasts. And now I need to do this and do that. It's going to be a list of like 200 things. I promise you that. You know, so what you really need to sit down and say is like, okay, what are the 2 or 3 things that I most need to get done? get those accomplished and make yourself feel good that you've got them off your list and moved on. And so it's a lot of things, but I think taking a stepwise process is pretty important.
I do want to ask, though, just play devil's advocate. Do any of us know, do other programs, specialties, sections, do any of that incorporate practice building into their training? I have never looked into it. I'm just curious because I don't know of anything that had that specifically, but maybe there is, and I just don't know. But that's something we can maybe look into and understand from.
I looked into that here, Kumar, and I think it's Kumar. That was Kumar, right? Yeah. I looked into that here. But, again, remember, their model is different. They kind of watch how their practices unfold, right, as they're training a surgeon or a cardiologist. Like I said, my cousin's interventional cardiologist. He came out. I asked him, what are you going to do? He knew exactly what he was going to do from A to Z, and he had no courses, nobody told him what to do and how to do it. It's just that it's kind of ingrained in them as they train because of the way their model, the way their program. Look, if our IR practices were set up where we every morning at 5 in the morning or 6 in the morning, we rounded with our IR fellows, whatever hospital or whatever location we're at. We saw all the patients. We write the notes. We write the consults. Everything's taken care of, just like surgery does. And then we do cases all day, get pages and phone calls. And at the end of the day at 8 o'clock, whenever we're done, like a surgery department does, we go re-round on everybody and see all the new stuff. You kind of, I think, and then you're in an outpatient clinic seeing, 40 patients during that day. You kind of naturally start picking up, and you're constantly making phone calls with your phone. You kind of slowly pick up some stuff, I think. But I know here, at least, they don't have any type of formal process like
For those clinic days, are residents or fellows like currently actively participating in clinic, or is that something that's kind of being expanded with the new training pathways?
We always have a fellow right now, in our clinic, and then when the residents right now, our first IR residents are PGY1s, PGY2s, but so they will be with us once they kind of get to their IR portion of it.
Same here. This is Kumar. Sorry, same here at our place.
Oh,
yeah, same at ours.
Very cool. The idea, like they would have maybe their own panel and things of patients and follow them pre, post, any follow up. Like that's kind of the model that you're going for. Were there any? I guess it's been kind of brought up a couple different times. You're kind of surrounded in one way as you come out and you're joining a group that's that's traditionally diagnostic with an interventional component that seems to be the most common. And there's one group, you have to sell your clinic time to them and kind of justify it to some degree, even before you begin to start to work with other specialties and demonstrate what you can do to them. Anything that you found, any challenges or anything that worked for you in sort of discussing, hey, I know I'm not going to be reading as many studies, but my time in clinic is worth it because of this.
I'll tell you, when I first joined my first practice, they really had no dedicated IR in the sense of a clinic or seeing patients and so forth. There's basically an order. Patient came down. That was the first time you would meet them and see them. And then you would kind of do your consult then and train them. But some of the things that I saw that worked were, is you have to, again, show your worth, right? And everything is numbers. It's all finances at the end of the day, regardless of what specialty you're in. And so what we did was we took all the procedures that we did. We looked at all the downstream effects, right? How much money, how many lab tests were ordered for that UFE? How many MRIs did we order pre and post? What was the other imaging studies that were ordered for a vascular patient, whether it was a non-invasive study, a CTA, MRA, etc., the intervention, the angiography, and so forth, and looked at how much are you making per patient beyond just the procedure? Because when you show people those types of numbers, whether it's a hospital administrator or your partners in your practice, then they get a better understanding of the importance of why seeing patients is important, why billing E&M codes, meaning the codes of just seeing a patient in the office, why having an actual office space and maybe some diagnostic equipment in there, whether it's ultrasound or otherwise. That starts to make more sense because they're looking at the dollars and cents to begin with, saying, whoa, every UFE makes this much? Wow, that's amazing. We need to get more UFEs. Well, then I need to be able to see more patients and see them in an office. So then you can start making your argument, slowly, piece by piece, to get to that point. I'm sure Venu, came into a phenomenal practice, right? A lot of this stuff was done by his predecessors, but I'm sure you struggle with that stuff on a daily basis, and probably Sabine and the others too. I know Kumar had to go through a lot of stuff to build his practice into what it is today. It wasn't like he just showed up and it was handed to him. So I think everybody has kind of a model they've worked with.
Yeah, Srini, this is Venu here. Yeah, I mean, I think you raise a good point, and it was a point, I was sort of alluding to earlier as well. This, clinical IR model and the practice building that goes with it, it's a constant work in progress. There's always new docs, new referring docs. I'll tell you, we end up having to do really, in a sense, sort of a orientation of sorts for the hospitalists that we get in the different hospitals where we cover, simply because most of them are coming out of places wherever they might have trained where IR wasn't involved in vascular, for example. And so the fact that we are not only involved with vascular, in fact, we're on vascular call. And so we have to sort of point out, hey, when you go into the paging system online or look for who's on call, that's our name on there. And so just to sort of educate them and orient them. And then, of course, look for opportunities to work with them to help their patients and, give them that orientation of sorts. But it is a kind of constant work in progress, and, making yourself available, doing those outreach, all those sort of things. It's not something that once you hit, a certain number a year, it's a cruise control and everything is just going to fall on your lap. It really isn't. And I think that's, one of the things whenever I have sort of sidebar conversations with, especially trainees, I kind of point out, knowing that, hey, I know I'm in a very good practice, but it's constant work to be in this practice. And it's like any kind of effort that you're going to put into something, you don't just sort of go and run a marathon and then you're suddenly really awesome at running marathons. Like you have to train at it and work at it. And same thing goes for practice building and the clinical IR model.
Yeah, and I'd like just to add that in addition to what Srini said about numbers, a lot of times in my group's understanding, I mean, we're a combined DR-IR group, and it's almost like IR is kind of the face of radiology. So we're out there, the clinicians are seeing us. They're not really seeing the radiologists who are reading the scans other than their name on the report. So we kind of use that as to really tie ourselves and ingrain ourselves into the hospital, because when it comes down to private practice, then you're contracted with the hospital and you have to have things to make yourself very valuable. A sole DR practice is pretty replaceable, but once you have a very good footprint in IR, the hospital can't really get rid of you. And so, that's a big thing. And our radiologists understand that and let us do whatever we need to keep that going.
Yeah, that's really cool to hear. I've kind of heard it said that you can kind of chip away even with more minor procedures, venous access and things like that. All those patients they'll usually have something else we can offer them down the line. And it just sort of, it all just becomes a web there, where you kind of stick yourself in the middle and it get tangled up with everyone else. We just kind of hit the 60-minute mark, and there's about 30 left if we keep going on our appointment here. So I just wanted to remind all the attendees that you can start to log questions live. Otherwise, we'll just kind of keep going with the ones that we've prearranged, just so that we don't run out of time at the end. I guess from the other side, after you kind of consider your partners in the diagnostic side, then you're dealing with other specialties. And I guess the theme was kind of arising. It was easier to be more collaborative instead of combative, so to speak, or and that, didn't know if anyone had any comments or could speak to that, how to sort of get yourself as part of the, let's say, vascular service line or the oncology service line. Any experiences there?
Well, one thing I did want to bring up, though, is when we were talking about the training, is that I think our residents and fellows, at least the residents that are in the IR integrate, the residency program, the ones that want to go into interventional radiology, we need to spend more time about how to evaluate a patient. We spend a lot of time on how to treat somebody, how to do a procedure and so forth, but just basic stuff about leg pain, leg swelling, somebody with liver disease, all the basic stuff of diagnosis, somebody comes in with arm thing, because you have to show, again, your worth, that you're a doctor. It's the hardest thing to convince somebody, because at the end of the day, they still see radiology in the name. They just think, it's a guy who likes to do procedures and that's about it. And so that's something that's very important. I think the other thing that helped me here at University of Miami, I came into a program that hadn't done vascular disease in 2 decades. But the first thing I told our vascular surgeons, I said, look, I'm here. I'd love to work with you. If you guys are interested, then let's do it. If not, you don't have to refer me any patients. That was the biggest thing that actually caused them to relax. And the reason they relaxed is because now they don't look at me as I'm here to steal their patients. Look, at the end of the day, look at who our referral pattern is, at least in the vascular disease space. Internal medicine, primary care, podiatry, wound care centers, et cetera, that's the exact same referral base for the vascular surgeon. So that's the reason they get all worked up and kind of intense about when a new IR doc or a new IR service line shows up in a program or a location. And so you're not going to be able to fight people. You just have to go out and hustle, like everybody's saying, and get your own patients. And that's not easy. It's a lot of work. It's a lot of phone calls. And it's a lot of people, you're almost kind of like you're cold calling people or like a used car salesman. They look at you and go, oh, great, I'll send you patients. They might send you zero. So I think collaboration is the best model. Trying to get everybody integrated to have the same mindset is great, but that's not always practical because all politics are local and every place you go is going to be different. But the number one thing you can never go wrong with, again, is going after and trying to get your own patients. And it's a fight and it's a lot of work, but that's what every other specialty and clinician does when they join a new hospital. They go out and they get their own patients and they try to convince people, I'm a good doctor. And I think that's the number one thing that helps a lot.
I agree with Srini. This is Keith here. I think one of the biggest successes of interventional radiology is the liver clinic. Okay, and the liver clinic has been successful because we are not stealing patients away. We are just helping them get transplant. Now, this is a completely different scenario when it comes to fibroids or prostate or vascular disease. There is, we are almost fighting for the same patients. So I don't know, collaborative practice works as long as you're helping somebody get to surgery. They're all in for you. They love you. You're the best guy ever. But when it's something that you can offer instead of surgery, it's difficult. So I don't know. We have tried collaborative practice in various things. The two most biggest successes are liver and PE. And one of the reasons PE has been a success because vascular surgery or CT surgery has not shown interest in it. And it's been, the pulmonary team, IR team, hematology getting involved and forming a PERT team. But if we do have CTS or if we do have vascular surgery involved or cardiology involved, I don't know what the scenario will be. So yeah, collaborative practice is tough. It's very tough. I think so.
Keith, so this is AJ. We were not doing just, they were asking for experiences. And, we were not doing nearly the number of like fibroid procedures that I would say is proportional to the size of town that Birmingham is. And, we did the clinic. I would email the GYN people. I'd offer to give talks. I'd offer to, all sorts of kind of things. Like anytime that there was a GYN patient for a nephrostomy tube placement or whatever, I mean, we were just always really on top of it, and it was just dead silence from the other end for a while. And then, finally, just as these guys were mentioning, we ended up kind of doing something with like hospital marketing. and like a video, and we ended up going on the news and doing some different kinds of things with some patient stories, and that finally got everybody's attention. And after that, they invited me to give grand rounds, and the point of the story is it's not really, I would even say in fibroids, it's not even fighting for the same patient. Because I had this really great graph talking about, the number of people with symptomatic fibroids, and, there's millions, there's like 3 million women that are just sitting around with symptomatic fibroids that aren't doing anything about it. And I think that was the point, to when I could show the GYNs, it's like, listen, we do like 400,000 hysterectomies. We do like 40,000 uterine fibroid embolizations in the United States per year. I'm not fighting to get 5 more so that you guys do 5 less. I'm talking about let's work together so we get these 3 million women off the sidelines, right? And that they can come in and make a decision about what it is that they want to do. And I think that was very eye-opening. And again, it's coming at it in a way where you're saying let's work together, right? Even with vascular surgery, I mean, there's patients with critical limb ischemia, PAD, these kinds of things that are just not being treated, right? So it's not like a tug of war about I'm going to do 10 more patients so you do 10 less. It's how can we work together so that we can increase the number of patients that we're all treating.
I think that's an excellent point that AJ and everybody's making. I mean, one thing we have to remember is that you don't have to necessarily argue or fight for patients within your own hospital. There's tons and tons of patients that are not even being addressed or given options from the outside. So I think part of what AJ does excellently is do a lot of outreach. Keith does a lot of that too. All of us try. There's a lot of education in the community to physicians outside the hospital. There's, in the CLI world, there's millions of people that don't even get to a physician to be properly evaluated. And, I think that's where we got to work hard on as well. Worrying about the battles internally, that's inevitable part of any practice. But I think you kind of do your job. You reach out to physicians. If they respond, but you keep trying, and you work more on the other the primary cares, the podiatrists, the family physicians who need better sources for patients. Maybe you can get to them faster and help them out. But I think as long as patients are given the options and they're aware of those options, we can do a lot better.
I think this fits in, Ted, into the whole IR residency paradigm in the sense of we have to start teaching our residents and fellows that nobody's going to send you a patient just because you're the hot shot on the block. They're not going to send you a patient because you trained at a certain place. They're not going to send you a patient because you're supposed to be technically better, whatever that means. In today's world, they're going to send it to you because you convince them to send you the patient, whatever that means, and that means, again, showing them who you are. Do they like you as a person? Do they think that you're safe? Do they think that you're competent? All those things help. But in today's world, the whole model, which is it's a archaic model at this point of the surgeon is going to send me all of this, or the gynecologist is going to send me all of this, is over. And it's going away faster now than it did even, 10 years ago. And I think once we learn, and you know what? I've sent probably 5-6 patients for bypass to our surgery department. And now all of a sudden they're kind of warming up and saying, all right, well, here's a case that we don't think we can do anything. What can you do? So it's a little bit of what everybody's talking about. But I think we got to train our residents and fellows not to expect referrals for kind of high-end glamorous procedures unless we're the only ones doing it. Then there's nowhere else for it to go.
Yes, Srini, you're right. This is Keith again. So we looked up, UFE and PAE referrals, and it's 30% referrals from surgeons and 70% are self-referrals. And the best part is, the PAE is a tough procedure, and the ones that are coming in from the urologists are the ones who are 85 with catheter dependent. The arteries are so difficult to get into. They take 3 hours to finish or 4 hours. Versus the self-referrals who are 50-year-old guys who don't want to be on medication. They just walk in, have clean arteries, and it's done. And they have better benefit than those 85-year-old guys. So the whole point is, collaborative practice can contribute to a certain amount of your referrals, but I think we have to go directly to the patients. And that's going to be the future of our specialty.
Yep, I agree.
Marketing ourselves directly to the patients, kind of what Dr. Gunn was starting to describe, making flyers and getting the message out. Are we seeing, or is anyone seeing a lot of referral, like self-referred patients already from some of those efforts?
Yes, we do see, as I said, the UFE especially has been about 70% self-referred. Yeah, and and the same thing on the PAE side. And I think SIR has been very cognitive of this, and as maybe AJ will throw some more light on this, but they've said that in the next 4-year plan, there's going to be a lot of new efforts towards direct patient marketing. And that's very refreshing for us because this is a completely new way of dealing with our specialty by SIR. We can do as much as we can at a local level, but I'm stopped at some point saying that why you're selling PAE so much, our urologists are there. Why are you selling UFE so much, our gynecologists are there. So there's only so much we can do at a local level. That's when the SIR comes in.
Yeah, I mean, they're just really kind of like planning stages. There's going to be, they're from a society level, they're looking to do a big push as far as patient information, kind of doing more direct to patient, and then also, working with other, on a national level, working more with other, physician societies, right, to kind of see where we can work together, those different kinds of things. But, it's all of it, right? I mean, it's. And I think if anybody's listening, that's what you need to hear from this. It's all of these things. It's worrying about the business side. It's dealing with the internal politics of your hospital. It's at the same time direct marketing to patients, and it's also working with those patients that are maybe being seen by a primary care doctor that don't know anything about IR. I mean, all of these areas are kind of like pots that you kind of have to work in order to make a well-rounded practice.
To any degree, has anyone had an experience where they sort of saw an opening for a procedure that maybe they didn't have exposure to in training, and then kind of sought some secondary training just to kind of deliver that and fill that gap in their kind of local system?
Sure, I can. This is Venu here. I think trainees should actually completely expect to see and learn things that they did not get exposure to during their training. There's so much out there. There's so many different things that people in practices do, and I think for somebody to come out of training and expect that they've sort of seen it all, if you will, I think actually is not realistic. So personally, I mean, some of the things I've learned in the practice here, I remember I started right on July 1st, and I think the first or second day in, there was a bone marrow biopsy that was ready. And I mean, I only remember doing that as a third-year medical student on oncology. I had never done that as part of IR. And so, okay, I had to learn something new. Granted, it's a fairly straightforward procedure, but I learned how to do it, and actually over time sort of developed an interest in it, made it into a project that we presented at one of the SIR meetings, because I think it is something that, is well within the wheelhouse of what an IR can do, because we can reach things with needles and do it very effectively and safely. But that was sort of a simple thing. And another area on the IO side of things, I had never been exposed to NanoKnife. And so that was something I learned from one of my senior partners, saw some cases here in the practice, went and did the sort of formal training course and things, and so incorporated that into my IO wheelhouse. So I think you should always have an open mind about not just learning things, but you might see something that and see a different way of doing something you already know how to do, and find that, hey, this might be a more efficient way, or that's a neat trick that somebody else has been using. And so I think just sort of keeping that open mind about learning new things is always important.
Yeah, I'll just say that too, is that really just exposing yourself in training to all different fields. I mean, for myself, I had never done any neuro before coming to my practice, and wish I had even just done proactive work in neuro. And like it's something that as a trainee you do have the option of seeing a lot of things, and should really take advantage of it, especially with this IR/DR path now.
There's I always tell the residency applicants when they come through that there's like no such thing as like a perfect IR program, because everywhere you go, you should, just like everybody's saying, you should really expect that you're going to bring something to your practice that they haven't done before, and that they're going to show you some things that excuse me, that you haven't done before. And so that's what's really great about IR in general. I mean, and I think that is, sorry guys, I think that that's one thing that's really awesome about going to a new place is that as a new person, it's really important for you to sit there and kind of look and see what they're up to, because for me, we did some filter retrievals as a fellow, but not like high level all the time, like we're using a laser every single day kind of filter retrievals. But in my first practice, I went and it just wasn't. There was no filter retrieval program set up. There was nobody really doing it or worried about it. And so I saw an opening for myself to kind of establish myself as a new partner, like, hey, let me work on this. And they were very happy for that. So it wasn't my passion. It wasn't the thing that I would have thought was going to be the thing that I was going to do when I first came out of practice. But you have to be open to those kinds of changes and be a contributing partner to where you go.
Thanks. That makes sense. Kind of making a space for yourself and filling in where you're needed. I mean, it helps that obviously there's such a wide range. You can kind of anticipate that no matter where you go, there'll be something you've seen that might not be being done yet. And then is it mostly learning from your colleagues, or are there other avenues for kind of this extended training, kind of a lifelong learning that you have found beneficial?
This is Kumar here. Learning from your colleagues is actually one of the best ways if they're already doing quite a bit of what you're trying to get into. But also, there are courses that are, usually industry sponsored or hospital sponsored that you can look into. I mean, you have to kind of pick and choose which ones you think are most beneficial and ask around about what the benefit of those are, what which ones are actually useful for you, especially when you're doing radial, like Keith and Venu do a lot of that at Sabine as well. There's a lot of courses around the country and everywhere where you can do kind of an in-depth, kind of advanced level training and seeing what to expect, complications. So I think for certain things there are courses that can help you, and now you can reach out to anybody you know and get some advice. The good catheter and wire skills that you develop in training with some kind of background knowledge and some supervision or assistance, I think we could kind of get to most places.
Great. There's a question about kind of flexibility and shaping your practice submitted from the audience. It's a little unclear if it's just about the type of procedure, or more it's about kind of your work split, your diagnostic and your interventional split. And I guess if anyone had any experiences, has everyone always been full IR where they are, or has anyone kind of had diagnostic responsibilities as well? And how did that kind of evolve, I guess, or change?
I mean, I had a lot of experience with that kind of early in my career. I mean, I'm like Venu and Sabine, I'm neuro trained. I did neuro at UCLA, and so I read MR and body imaging and so forth. And so when I first came out, probably the first job I took, the interventional rotation was one guy, which was usually me or my partner, and in between we had to read the head CTs from the ER, or a stroke MR, or a chest X-ray, or whatever it is, a body CT, etc. And I'll tell you, it was tough because it puts you in a position where you're kind of like, you don't want to do complex cases, because then this other list on the side starts piling up. And so what we did was we went to the group and we said, look, I said, this is not helping either of us, whether it's the diagnostic work, it's not helping the patients on that side. It's not helping the patients on the IR side, because we can offer a lot more. And so we came to more of like a kind of a compromise, which is that they would leave a certain number of non-emergent studies, maybe outpatients, etc., that we could read per day. And this was our tally, whatever it is, 20, 15, 30, whatever you want to. And then we would basically do our IR work, would then allow us to be more aggressive, try to do more complex cases, try to practice build. And then when you're done, or if you have time during the day, you kind of start going through your list. And so by the time you leave, you finish that. And you'll say, well, that stinks, because you're doing a full day of IR at some point, and then you're reading those. Yes, that's true. But as the IR got busier, then we were able to do less and less diagnostic. And so that is kind of the way we came up with kind of an internal compromise with the group. And most practices are willing to compromise if, again, you can show your worth. I mean, that's really what it comes down to, right? It's if you show, I'm doing this over here instead of that, but I'm bringing in this, or we're doing this, or it's helping the group and the practice as a whole, they get it most of the time, right? It's not going to be everybody, but that's part of being in a family or in a big practice. You have to convince people. So that was my experience.
Yeah, to this is Venu here. To the point of sort of question earlier about how do you sort of acquire these things, as Kumar was sort of pointing out, partners are certainly a great resource. Training courses, there's tons of them. In fact, I think probably most of us have experienced that the reps for the different companies will offer you huge smorgasbord of courses and things, and frankly you just have to pick and choose which ones are going to be worth your while or not. And then, and frankly, I think if you sort of get to a certain internal comfort level, you want to, of course, always be growing and look to push yourself to, become a better IR. And you can, frankly, you can learn a lot of things. There are definitely resources out there, whether it's, things in literature, phone of friends, whatever it might be. But, if you sort of get an understanding of something and you feel you can do it safely, and you've built up that reputation both externally amongst referring docs, but also just an honest assessment internally that you think you can do something safely. There's no reason you can't sort of forge ahead and learn a new skill set, even outside of, let's say, a formal course. As Kumar was pointing out, in my practice, I do quite a bit of radial work, which I did not learn at all during formal fellowship, and really just it got to a point in my practice here that I felt, hey, I think there's some good evidence behind this. I think there's some good people to learn from. For example, some of the guys at Mount Sinai who've been doing it longer than I have, and so those resources were around. And ultimately, I just sort of bit the bullet in a sense, and I said, hey, you know what? I want to do my next UAE. I want to do it from a radial approach, and let's figure out. And some of it may be some figuring out parts, but I think if you have built up that skill set and confidence, and your complication rates are low, I think you can always pick up on new skills.
Believe it or not, even in addition to going to these courses and reading as much as you can and talking to people in our specialty that do a lot of these, I mean, I bug Venu, Sabine, I've called Age, I've called everybody about something at some point. What do you guys think about this? But you can learn a lot from YouTube as well, in terms of just watching kind of how people do certain types of procedures and what's their techniques and how do they do it, just to kind of help you round out kind of the reading and the stuff that you're learning when you go to some of these courses. It's you got to be careful. You want to go to reputable sites and reputable people who are doing these procedures, but you can learn a lot from YouTube.
That's great. I think it looks like we're running a little low on time, and we'll probably get shut down pretty soon. So I guess just take the opportunity to thank everybody. And if you have any kind of parting thoughts, words of wisdom, or advice for our attendees that just hasn't been covered yet, you can go ahead and toss that out there. I'm going to look for questions.
I'd like to just say, as Kumar, thanks everybody for taking the time. I think for all the listeners and for the future trainees out there, things are moving in the right direction. I think we're all invested into making a bigger impact in the medical world for our patients, and that's what we got to remember every time. So I look forward to seeing where we go with this.
Yeah, and I think interventional radiology is here to stay. I think it's only going to get better year after year, and it's a great special to be a part of now and over the next couple of decades. I strongly believe that. I think if you're something you love to do, I think you'll love it even more.
Yeah, this is Venu here, and I echo the thoughts of Kumar and Srini, and one thing that was, said earlier on, I think, AJ pointed out, when you get out into the practice, I think, a couple of key points, work real hard, sort of keep your head down, learn where you can, including from your partners, and then always look for those opportunities for practice building. And it's not necessarily always something where you're handing out flyers. It may be simply taking the time to get to know, one of the clinicians on a more personal note or something like that, where you can ultimately translate that to also becoming a better professional relationship, because that's also part of practice building. And so those sort of efforts, as well as, of course, the more modern type of things with social media and outreach and those sort of efforts, I think will ultimately give people, I feel, a fulfilling and successful career.
Yeah, I'd like to thank everybody for taking the time to. But it's a great specialty. It really it's fantastic, and it's still a small specialty. So, people are really supportive of the medical students and the trainees that really want to go into interventional radiology. So, for those that are listening, always, feel free to reach out to people over email or whatever if you've got questions about all of this kind of stuff, because my experience is that people have been more than helpful and more than responsive over email, text, those different kinds of things. So.
Yeah, I completely agree with AJ. It's a great specialty, and really don't ever be afraid to ask for help, whether it's from your partners or from any of us or anyone in the field. I think it's a very big field that's built on camaraderie, and I think everyone's here to help each other.
I think that's one of the coolest things as a trainee to see, especially over social media. It's kind of a common gathering place for everybody at all levels. I mean, from patients to obviously more seasoned staff, and as everyone's sharing advice, and I mean, you learn, see new terms, able to look things up, and obviously, I mean, just basically everyone's getting something out of this same tool and really kind of furthering the field in a lot of different ways. So I'm gonna move along to our next slide here. Speaking of which, just have some contact information for anyone who's attending. Oh, got a question coming in. If you'd like to get in touch with anybody, I found it is easier to find them all on Twitter. Yeah, with that, just like to thank everyone who tuned in, and stay tuned. We're gonna put together another presentation sometime in the near future. Get kind of more in the weeds of various practice settings. So thank you. Good night.
Thanks, everybody.
Thank you.
Appreciate it.
Thanks, everybody.
Thank you.
Thank you. Thanks, everyone.